All right, thanks so much, Brad, and thanks to the organizers for the invitation to come to Memphis and speak to you all today. So my task is really to review some key highlights in both kidney cancer and bladder cancer, all within 20 minutes. We have a lot to unpack, so we're going to get started. So starting with kidney cancer in the metastatic setting, many of us are familiar with the IMDC criteria, which is a well-validated prognostic scoring system looking at laboratory parameters, disease timing, and patient's performance status. And it gives us some key categories that give prognostic value. So you have favorable risk disease, which have the best prognosis. And then you also have intermediate and poor risk disease, which have much worse prognosis overall. The IMDC criteria has also been used as a stratification tool in many of the key landmark trials in kidney cancer, and also has been used as a tool to help us select treatment strategies for our first-line therapies for kidney cancer. But as we'll see in a moment, I think the role of IMDC criteria is a little bit questionable moving forward with some recent data. So here's the kind of the first-line metastatic clear cell RCC treatment options. You have doublet immunotherapy with ipi/nivo. You have several IO-TKI combinations such as pembrolizumab and axitinib, nivolumab and cabozantinib, and pembrolizumab plus lenvatinib, and several TKI monotherapy agents overall. As we look at the key major 4 trials in kidney cancer, all of these have demonstrated excellent overall survival and PFS benefits in their respective phase 3 trials. But as we'll see later, there's some nuances in choosing one of the other regimens. So first diving into Checkmate 214, this is a study of ipilimumab and nivolumab. So in this study was a phase 3 study of patients with advanced clear cell kidney cancer who have no prior therapies, and patients were randomized to ipi/nivo or sunitinib. And the key primary endpoints of the study were overall survival, PFS, and response rate in the intermediate and poor risk population. And as you can see at the time of the initial analysis, there was a really good benefit with ipi/nivo in patients with intermediate and poor risk disease in terms of overall survival and PFS. In contrast, for patients with favorable risk disease, there was no benefit, and actually at the time of this analysis, they actually did better with sunitinib. But based on the initial analysis from this study, it was a category 1 recommendation specifically for patients with intermediate and poor risk disease. Now, we have also learned about sarcomatoid RCC being a predictive biomarker in ipi/nivo. So sarcomatoid RCC is a really aggressive histologic subset with really poor prognosis, but they do have a paradoxical response to ipi/nivo. So this was a subset analysis from Checkmate 214, which clearly shows that patients with sarcomatoid RCC really had deep and durable responses with the combination. So this is certainly a biomarker that we should be really considering to help us select for ipi/nivo. More recently, we had 8-year follow-up data from Checkmate 214. So you can clearly see that in this cohort, we have long-term durable responses with ipi/nivo. I do want to highlight in the curve here that it's really remarkable to think about. There's 35% of patients still alive at 8 years. So it really highlights the point that when we see a patient in clinic with metastatic kidney cancer, we should really be striving to really think about potentially curing them of their disease. Also with extended follow-up, we do see that patients with favorable risk disease now have a flip in the curve in terms of a non-significant OS benefit. And I think this really challenges the notion of IMDC criteria because historically we thought that favorable risk disease was more angiogenic and less immunogenic, and therefore they responded better to TKI monotherapy as opposed to ipi/nivo. But clearly, as you can see in this subset analysis, many of the patients are still deriving good benefit with ipi/nivo. So because of this data, it is now a new category 2A recommendation in favorable risk disease. So just as a summary of the key trials in kidney cancer, like I mentioned, IMDC criteria is helpful, but I think its utility in first-line decisions may become relevant. Ipi/nivo, as of now, has the longest follow-up data to date with long-term durable responses, and again, highlights the potential for cure in these patients, but there is a higher disease progression rate. In contrast, IO-TKI regimens have a higher response rate and a lower disease progression rate, so this is my preferred approach for patients with symptomatic disease who need quick cytoreduction. As we move on to second-line and beyond considerations, we have several agents available. You have TKI monotherapies and other oral targeted agents. But the truth is we really do not have a preferred regimen in the refractory setting, and we really have limited data on the optimal sequencing of subsequent therapies. So as you saw in the previous slides, first-line treatment is really consists of immune checkpoint inhibitors in most of the regimens, but The big challenge that we face in clinic is, if a patient has disease progression, should we re-challenge them with immunotherapy? And we do see this as a common practice in real-world practice. So maybe a patient got first-line ipi/nivo, but at progression, they were then treated with pembrolizumab and axitinib. But despite the contrary, we don't have the best evidence in the past to really support if this was really a good decision or not. But we do have the recent study called CONTACT-03. This specifically looked at the question of IO rechallenging. And in this trial, patients had metastatic kidney cancer who've had disease progression on an immediately preceding line of prior immunotherapy. And here, patients were randomized to cabozantinib or cabozantinib plus atezolizumab. And the key dual primary endpoints of this study were PFS and OS. And of course, in the analysis, there was no improvement in outcomes with cabozantinib and atezolizumab after progression with immunotherapy. Now, there were several criticisms of the study, one of which was the ongoing debate between PD-1 versus PD-L1 activity in clear cell kidney cancer. So we looked to the recent TiNivo-2 study, which was a very similarly designed study looking at patients with advanced kidney cancer who had 1 to 2 prior lines of therapy, including an immunotherapy beforehand. And here, patients were randomized to tivozanib monotherapy at 1.34 milligrams versus tivozanib at 0.89 milligrams plus nivolumab. And the primary endpoint of this study was PFS. And of course, there was no significantly statistical difference in outcomes with the combination of tivozanib and nivolumab after immunotherapy. So bottom line is, the role of immunotherapy rechallenging should not be done in kidney cancer. Now, as we look in the refractory setting, we have a new agent on the block called belzutifan. Just a little bit of background in the biology. Von Hippel-Lindau syndrome, or VHL syndrome, is characterized by germline inactivation of the VHL gene, which leads to HIF-2alpha overactivation. However, somatic VHL mutations are seen in about 50% of patients with sporadic kidney cancer, and belzutifan is a recently FDA-approved HIF-2alpha inhibitor for both VHL-associated and sporadic metastatic kidney cancer. And this was really looked at in the LIGHTSPARK-005 study. And here, patients with metastatic clear cell kidney cancer who've had 1 to 3 prior lines of therapy, including 1 TKI and 1 immunotherapy agent, they were randomized to belzutifan or everolimus. And the dual primary endpoints of the study was PFS and overall survival. And at the initial interim analysis from last year, we do see that the 18-month PFS rate was 24% with belzutifan versus 8% with everolimus. And you had better response rates favoring belzutifan as well. But at the time of this analysis, overall survival data was still immature. Now, what's striking about belzutifan is that it has a notably different toxicity profile compared to many of the TKI agents. So you have most common all-grade adverse events with belzutifan are notably anemia and fatigue, but less than 5% of patients had all-grade rash or stomatitis that we typically see with TKIs. And here in the study, only 6% of patients stopped belzutifan due to toxicities. And we also have really interesting patient-reported outcomes data showing that belzutifan has a delayed deterioration in kidney cancer disease-related symptoms and global quality of life metrics. So I think when you see a patient in a refractory setting, they may have had several TKIs exposures, and they're probably having some difficulty with the toxicities. I think belzutifan certainly has its place in this setting. So moving briefly to adjuvant therapy for kidney cancer, the story of adjuvant kidney therapy in kidney cancer has been really perplexing. So we've had 3 studies looking at atezolizumab, ipi/nivo, and perioperative nivolumab, all of which were completely negative in terms of not meeting the bar for disease-free survival benefit. But we do have the recent KEYNOTE-564 study. And here, patients with clear cell kidney cancer who've had nephrectomy with adverse pathologic features that you can see there on the screen, as well as patients with M1 disease who were rendered no evidence of disease after surgery, they were randomized to 1 year of pembrolizumab or placebo. And here, the primary endpoint was disease-free survival per the investigator. And at the initial analysis, it did meet its primary endpoint with a DFS benefit with a hazard ratio of 0.68. And at the time, overall survival, there was a trend for OS benefit, but still was quite immature. But nonetheless, adjuvant pembro was approved for clear cell kidney cancer at intermediate and high risk of recurrence. Now, we recently had updated data showing sustained DFS benefit with adjuvant pembrolizumab, as you can see here. We also now have an overall survival benefit with a hazard ratio of 0.62. So this certainly has moved the needle, as we just discussed with patients, in terms of adjuvant pembrolizumab as an option for patients who are at high risk of recurrence. Now, there are certainly remaining questions about adjuvant immunotherapy and pembrolizumab. Certainly, patients who have progression after adjuvant pembrolizumab, we don't really know if what's the utility of using first-line immunotherapy-containing regimens. And certainly, we have to be really more sophisticated in terms of selecting patients for this strategy. There's some really exciting data looking at KIM-1, which is a biomarker that was first studied in nephrology, stands for kidney injury molecule number 1. And this may be a potential biomarker moving forward. I think when you look at other data sets, you can clearly see that high KIM-1 circulation in the blood is associated with worse prognosis, so a higher risk of DFS, but also may be predictive of patients getting benefit from adjuvant immunotherapy. So we'll have to need some further validation and prospective evaluation of this biomarker. So here's a summary of the kidney cancer highlights from this year. So Ipi-Nivo has the longest follow-up data so far. There's also encouraging OS benefit even in favorable risk kidney cancer. Based on the CONTACT-03 and TiNivo-2 studies, we should not be re-challenged with immunotherapy after progression. And then belzutifan is an option in the refractory setting, especially for those that are wanting for something that's a little bit more tolerable than your traditional TKIs. And with adjuvant pembrolizumab, it is approved, and we finally now have an overall survival benefit, which is a really big achievement in our field. All right, so moving on to bladder cancer, specifically looking at perioperative management of muscle-invasive bladder cancer. So here's a really brief, simplified overview of our current perioperative approach for muscle-invasive bladder cancer for now. But as you can see, we first determine if patients are eligible for surgery or wanting to pursue surgery. Otherwise, we do think about chemoradiation as a bladder-sparing technique, but for the purposes of this talk, I won't be discussing chemoradiation. But otherwise, if a patient is eligible or interested in surgery, we first determine if they are cisplatin candidates, and we have typically used the Galsky criteria, which is derived from the metastatic bladder cancer setting. This looks at various factors, including a creatinine clearance of 60 or higher. And if they are eligible for cisplatin-based chemotherapy, we typically think about Dosden's IMVAC or GemCis as neoadjuvant chemotherapy, followed by cystectomy. If they are not eligible for cisplatin chemotherapy, they go straight to surgery. In either cases, we also consider adjuvant therapy afterwards, such as nivolumab, depending on adverse pathologic features at the time of cystectomy. And in patients who did not get chemotherapy beforehand and are now eligible, we do think about adjuvant chemotherapy. So diving into the role of adjuvant nivolumab, this study was based on the Checkmate 274 study, which looked at patients with all the pathologic features that you see there. And they were randomized to 1 year of nivolumab or placebo, and the primary endpoint of the study was DFS in the ITT population and in those with positive PD-L1 status. So as you can see, the study was positive in that it demonstrated DFS benefit with a hazard ratio of 0.72 in the intention to treat population. But also in the PD-L1 positive patient population, you do see a much bigger magnitude of response. But nonetheless, adjuvant nivolumab is FDA approved for muscle-invasive bladder cancer after cystectomy at high risk of recurrence, regardless of PD-L1 status. We recently had updated data which shows sustained DFS benefit and overall survival benefit in both the ITT population, as you can see here, as well as, again, the patients with PD-L1 positive status. They seem to have much bigger response in terms of DFS and OS. We also had the recent study called the Ambassador, which looked at adjuvant pembrolizumab, very similar patient population with the exception that this also included patients with positive margins. And here, patients were randomized to 1 year of adjuvant pembrolizumab or observation. And the study had dual primary endpoints of DFS and overall survival. And at the time of the initial analysis, you did see that the study did meet one of its primary endpoints of DFS benefit in the ITT population with a hazard ratio of 0.73. Interestingly, in the PD-L1 positive group, there was no statistically significant difference, which is a little bit different than the Checkmate 274 data that we see where PD-L1 may be a little bit more predictive here. So certainly in this data set, PD-L1 is prognostic, but potentially not predictive of IO response. And of course, when you look at overall survival data, there was no difference. Of course, we need additional follow-up for this, but it is possible that since the timing of the study was after or during the Checkmate 274 approval, many of the patients in the control arm ended up receiving post-protocol immunotherapy, so that could have impacted overall survival reportings here. Now, the biggest story in bladder cancer from this year was the Niagara study. It was a much talked about study. This looked at perioperative gemcitabine cisplatin plus durvalumab. And in terms of the key patient population, this looked at cisplatin eligible muscle-invasive bladder cancer, so T2 to T4, but it also included patients with node-positive disease. And also, interestingly, patients with creatinine clearance of 40 or higher were allowed with the role of split dosing of gemcitabine. So patients were randomized to the durvalumab arm or the control arm, durvalumab arm getting 4 cycles of gem-cis-durva, followed by radical cystectomy, and regardless of what they saw in pathology, they all ended up getting 8 cycles of adjuvant durvalumab. In contrast, the comparator arm only got gemcitabine cisplatin for 4 cycles, followed by observation. The dual primary endpoints of the study was EFS and pathologic CR. So it was positive. So this study did meet the event-free survival benefit with durvalumab with a hazard ratio of 0.68. And then you see that benefit with EFS was basically consistent with among many of the cohorts you can see here, and it was really irrespective of PD-L1 expression on surgery specimen. And then the other co-primary endpoint was the pathologic CR rate. At the first analysis, it wasn't positive in that it didn't meet the pre-specified statistical significance of a p-value of 0.001, but they apparently found 59 samples that needed to be reanalyzed, and they finally showed a big difference that the path CR rate in the durvalumab arm was 37% versus 28% with the control arm. And important to our patients as well, it did meet overall survival improvements as well with a hazard ratio of 0.75. So my takeaways from the Niagara study is that it is a potentially practice-changing regimen for muscle-invasive bladder cancer. We are certainly awaiting for FDA and regulatory approval, but some have adopted this regimen already. But there are several remaining questions that we have to answer as a field. We don't know what the contribution between neoadjuvant versus adjuvant portion of this regimen is. And the control arm, like I mentioned, did not receive immunotherapy based on the Checkmate 274 study, so this may have impacted outcomes. But in contrast, patients with pathologic CR, is adjuvant therapy really needed? Are we potentially overtreating patients with pathologic CR? Because all these patients, regardless of their surgical pathology, they ended up getting adjuvant durvalumab. And is there a role for ctDNA in selecting those patients who might need and benefit from adjuvant durvalumab? And the big question is, will Niagara remain relevant in the context of other ongoing perioperative studies? So we have a lot of big studies going on. I think the big elephant in the room is the enfortumab vedotin plus pembrolizumab data. So we have EV303 and EV304 looking at perioperative EV pembro. So many of us are anxiously awaiting the results of this one. And we also have the Volga trial looking at enfortumab plus durvalumab with or without tremelimumab. So these are hopefully going to be really important additions to the data in this space. In terms of other perioperative approaches from this year, I won't highlight many of them, but this one's a really interesting one. This is called Sunrise 4, looking at TAR-200, which is a pretzel device that you can see in the bladder. I've been told by urologists that despite its unusual shape, it can be removed from the bladder, so I don't know how that's possible, but it basically contains a slow-eluting gemcitabine in the bladder. And in this study, it looked at patients with TAR-200 plus citralumab immunotherapy agent versus citralumab alone, all in the neoadjuvant setting. And you can see that at the initial analysis, the combination of the pretzel device plus immunotherapy did have a pretty impressive pathologic CR rate of 42% compared to 23% with immunotherapy alone. Now, there's a lot of exciting data looking at ctDNA in muscle-invasive bladder cancer. It is potentially prognostic of patients at high risk of recurrence and also potentially predictive of patients who might benefit from adjuvant immunotherapy. We do have some recent data incorporating ctDNA in muscle-invasive bladder cancer. So on the left, you have the Tombola study, which looks at patients who receive neoadjuvant chemotherapy followed by cystectomy, and they undergo serial ctDNA monitoring with Signatera. And at ctDNA detection, they are then treated with atezolizumab. And as you can see at the initial analysis, this ctDNA-guided approach certainly is able to improve DFS and overall survival, so it might be a potentially interesting tool for us in the future. We also had an exploratory analysis from the Volga trial. Again, this is a study of enfortumab plus durvalumab with or without tremelimumab. In a very small number of patients, we see that ctDNA clearance after neoadjuvant chemotherapy may be associated with higher pathologic CR rates and also better event-free survival improvements as well. A big study that's going on is the MODERN study through the Alliance Consortium. This is looking at patients at high risk of recurrence following neoadjuvant chemotherapy or without chemotherapy, and they will all get Signatera testing, and if they have a positive ctDNA test, they will be then randomized to either nivolumab for 1 year or nivolumab plus relatlimab. And for patients with negative ctDNA, they will be then randomized to either nivolumab or surveillance with serial ctDNA detection and then triggering the nivolumab at ctDNA detection. So that should be a really exciting study rolling out soon. So just real briefly for the last minute, we'll touch upon metastatic bladder cancer. So this is a paradigm that we used in the past couple years. So basically, frontline therapy really consisted of platinum-based chemotherapy or upfront immune checkpoint inhibitors. But our world was rocked with the recent data from the EV-Pembro data, which showed that it was superior to chemotherapy in terms of PFS and overall survival. So it is a newly approved first-line regimen for metastatic bladder cancer that we are all learning right now. So here's our current approach to metastatic bladder cancer. So again, first-line therapy is EV-Pembro. In areas that don't have EV-Pembro, we also can consider Gem/Cis/Nivo as well. But in the second-line setting, we have several agents, but we really have limited data on optimal subsequent therapies. There's some really exciting work looking at HER2 data in metastatic bladder cancer. HER2 is expressed in variability in bladder cancer in 13 to 25% of cases. There's some conflicting data of the prognostic value of HER2 in bladder cancer, but maybe associated with high risk of metastases. And way back in 2007, there was an early study looking at trastuzumab plus chemotherapy, which had encouraging response rates, but really frequent cardiotoxicity events. So that kind of limited the approach moving forward. But we do have interesting data from the Destiny Pan-Tumor02 study, which looked at patients with HER2-positive solid tumors who've had prior lines of therapy. And in this basket trial, we did have 41 patients with bladder cancer who were HER2, and you see the response rate was 39% overall, but in the IHC3 plus group, their response rate was 56%. So based on the results of this study, it is FDA approved for the refractory HER2-positive IHC3 plus solid tumors, including metastatic bladder cancer. We do have interesting data looking at a novel HER2-targeted antibody-drug conjugate called disitamab vedotin plus pembrolizumab. This is a study that was read out recently at ESMO, which looked at patients with HER2-positive metastatic bladder cancer per CAP guidelines. And they were all untreated, and they received DV plus pembro. And you can see the response rate was a really impressive 75%, even with activity in the HER2-low population. So this may be an interesting regimen moving forward in terms of our HER2-positive patients. So just a summary of the bladder cancer field, perioperative management is quickly evolving for muscle-invasive bladder cancer. We're going to see a lot of paradigm shifts in the next coming years. Niagara is very encouraging, so we're waiting for regulatory approval, but there are several other perioperative trials that are ongoing. This may take first place, to be honest, so we'll see what the future data holds. And there's a lot of exciting data looking at ctDNA in adjuvant strategies. And in metastatic bladder cancer, our landscape was revolutionized with first-line EV-Pembro, but we have also exciting work looking at trastuzumab deruxtecan and other HER2 strategies for our patients here. So, awesome. Thank you so much.
Thank you so much.